Hello, welcome to the IWMF 2020 Virtual Education Forum. I'm Peter Donardis. I'm a WM patient. I was diagnosed in 2003, and I also serve on the IWMF Board of Trustees. It's my distinct honor today to be introducing Dr. Jorge Castillo of the Bing Center for Waldenstrom's Macroglobulinemia at the Dana-Farber Cancer Institute. Dr. Castillo sees over 1,000 patients a year, and his clinic is devoted specifically to WM patients. Today, Dr. Castillo will be guiding us in a look to the future of Waldenstrom's macroglobulinemia. At the conclusion of this lecture, Dr. Castillo will answer as many of the questions that were submitted as possible, given the time that's remaining. Thank you. Now on to you, Dr. Castillo.
Hi, today we're going to be talking about a look into the future, treatments on the horizon for patients with Waldenstrom's macroglobulinemia. I think you know me well. I'm Jorge Castillo from the Dana-Farber Cancer Institute, Bing Center for Waldenstrom's macroglobulinemia. So for the next 35-40 minutes, we're going to be talking about what are the new treatments that I'm actually excited about for the treatment of patients with Waldenstrom's macroglobulinemia. So let's start kind of reviewing very briefly the different manifestations of the disease. And again, as most patients can be treated because of anemia, we also have patients who need to be treated because of symptomatic hyperviscosity, and this is classically manifested by nosebleeds and recurrent headaches and some blurred vision that can sometimes be due to the presence of microhemorrhages in the retinas. Some patients can have neuropathy, called agglutinin disease, cryoglobulins, lymphadenopathy, or organomegaly, such as large spleen or large liver. We have very rare patients who have brain and spine involvement by Waldenstrom's. We call that a Bing-Neill syndrome. Even more rare, we have renal involvements and sometimes pleural effusion secondary to Waldenstrom's. All these are indications to treat patients with Waldenstrom's macroglobulinemia. I think a review of the genomic profile of patients with Waldenstrom's is of interest, as these basically drives a lot of the future research in clinical trials that we want to be talking about today. The discovery of the MYD88 mutation in 2012 by Dr. Trion and the research group at the Bing Center basically paved the way for the development of a number of treatment options that are directed specifically at MYD88 signaling. As you can see there, multiple studies have validated the presence of these mutations in a large majority of patients with Waldenstrom's macroglobulinemia. At this time, I would say about anywhere between 90–95% of patients with Waldenstrom's will have a mutation in the MYD88 gene. Just to refresh your memories, this is not a congenital mutation, meaning you are not born with this mutation. It's an acquired mutation that is present only in your malignant cells, and therefore you don't pass on these mutations to your children, and you did not get these mutations from your parents. A second set of mutations that was described in 2014 by our research group as well are located in a gene called CXCR4, has to do with the homing of cells, into the bone marrow, and about 30–40% of patients with Waldenstrom's can have a mutation in CXCR4. There are a couple of different types of mutations in CXCR4, either nonsense or frame shift. We're still trying to understand what those mutations actually mean for the response to treatment and the care of patients with Waldenstrom's. And again, multiple studies from Europe and Asia had validated our findings, making this a true biological development. Now, this slide is not to try to confuse you, but rather to emphasize how our understanding of the MYD88 and CXCR4 mutation has evolved over time, specifically because I wanted to bring your attention to the presence of BTK as a very important molecular component of the activation pathway of the MYD88 L265P mutation. So this mutation activates, is an inherent activated molecule, and that generates the formation of a mitosome, of which BTK is a central point of importance, and therefore this drove the development of BTK inhibitors for the treatment of patients with Waldenstrom's macroglobulinemia. And the reason I'm pinpointing this aspect is because a lot of the future research coming down the road in patients with Waldenstrom's have to do with BTK inhibitors, as you will see later on. So Ibrutinib, as you know, is a medication that is already approved by the FDA since 2015 for the treatment of patients with Waldenstrom's. The combination of Ibrutinib and rituximab was approved by the FDA for Waldenstrom's as well in 2018. And therefore, combining Ibrutinib with other agents is of great clinical interest, and multiple research projects are evaluating these combinations. I want to show just an example of how some of these combinations and how the designs of these studies are working out. So this is a very brief slide just to show you the science behind this. This is not just an effort of bringing a medication and adding another medication and see, if that actually works. This is actually research efforts based on research and science. On the left, we see a combination of BTK inhibitors and proteasome inhibitors like bortezomib and carfilzomib and ixazomib. And we can see, if you look at the different columns, how the first three columns in each group are shorter, meaning the cell death is lower. But when we combine a proteasome inhibitor with ibrutinib, the columns that represent cell death are much higher. That means that there's synergy in trying to kill these cells. These are laboratory studies. On the right, very similarly, we have combinations of ibrutinib and daratumumab, which is an antibody against CD38, approved already for myeloma. And very similarly, we see, in each group of columns, the first three columns are kind of on the shorter side. The last column on the right, which is the blue column, is the combination of ibrutinib and daratumumab that actually shows a higher degree of cell killing. And again, this is a laboratory study. So this is what drives our interest on combining these medications and see if we can see in patients what we are seeing in cells. So one of the interesting combinations is a combination of ibrutinib, bortezomib, and rituximab. This is for patients who have not been previously treated, and this is being done in Germany at this time. They are using subcutaneous bortezomib and subcutaneous rituximab and ibrutinib. Rituximab and bortezomib and ibrutinib are being given for 6 months as an induction, as you can see here. Rituximab is given initially intravenous, and you can see the dark column, and then subcutaneous, and you can see the somewhat lighter columns down the road, and this is given once a month for 6 months. Bortezomib is given subcutaneously on day 1, 8, and 15 every 4 weeks, and again, we do this for about 6 months. So this is what we call the induction treatment, which lasts 6 months. After that, patients will continue on ibrutinib, and then bortezomib will be dropped, and rituximab will be continued every 2 months as a maintenance for about 24 months, up to 24 months. After that, all rituximab therapy will be stopped, and patients will continue on ibrutinib until disease progression or unacceptable toxicity. So this is a study that is already enrolling patients and is available for the entire country of Germany at this time. The next proteasome inhibitor is carfilzomib. Carfilzomib is also a proteasome inhibitor, but it has a very slightly chemical composition that is different than bortezomib, and therefore does not seem to induce the same degree of neuropathy that bortezomib does. The difference is carfilzomib needs to be given intravenously. This is also a study that is going to be run in Germany, and it's not enrolling yet, probably will be enrolling later on once these issues with the COVID-19 probably get a little bit better. And this is going to be a randomized study, meaning 184 patients will be selected, 92 will be put into ibrutinib alone, and the other 92 in a combination of carfilzomib and rituximab. And as you can see here, the study is divided in 2 sections, the induction section and the maintenance section. The induction section is going to be carfilzomib on days 1, 8, and 15 for about 12 cycles, and ibrutinib along the way every day. And the maintenance phase is going to be carfilzomib on day 1 and 15 only, so just 2 times per cycle for 12 additional months. So a total treatment duration of carfilzomib of 24 months. Ibrutinib will continue from day 1 all the way until disease progression or unacceptable toxicity. This study is not open yet for enrollment, but is going to be enrolling very, very shortly. And it's important to know that this is a randomized study. So there's going to be a comparative component to this, comparing against ibrutinib alone. The next proteasome inhibitor is the oral agent ixazomib. So ixazomib is essentially a very similar compound as bortezomib, but it's given by mouth. And by being given by mouth, we believe the risk of neuropathy decreases dramatically. At least our experience with ixazomib and dexamethasone and rituximab in Waldenstrom's have shown really that the rate of severe neuropathy is very, very small. This is a study that is being done by the Mayo Clinic in combination with the in collaboration with the National Cancer Institute. 47 patients will be added to this, and this is going to be specifically on relapse refractory patients with Waldenstrom's. And as you can see here, this is up to 24 months of therapy with ixazomib. Ixazomib will be given orally on days 1, 8, and 15 every 4 weeks, up to 24 cycles. Ibrutinib will continue all the way to disease progression or unacceptable toxicity. We expect that any of these, hopefully these combinations of therapies will induce a deep response that is hopefully going to be sustained. And just to finalize this section, I want to present the design of the study of ibrutinib and daratumumab in patients with Waldenstrom's. This is a collaborative effort between Weill Cornell and Mayo Clinic as well. 24 participants will be added to this study, of which there are going to be 2 components of this. One of them is going to be patients who have never received ibrutinib. They could be either treatment naive or relapsed. But also, they're going to include some patients who reach a plateau to ibrutinib, which means that they started on ibrutinib at some point in the past. They reach a situation in which the IgM does not decline any further, and at that moment, daratumumab will be added to these patients to see if a deeper response could be induced. In this study, patients continue on ibrutinib daily all the way to disease progression or toxicity. Daratumumab will be given once a week for the first 8 weeks, and that's an induction phase of 2 months. And then daratumumab will be given every 2 weeks for 16 weeks, and that's a consolidation of about 4 months, followed by monthly infusions of daratumumab for 18 more doses for an additional duration of 18 months. So this is a 2-year therapy as well, but ibrutinib continues indefinitely. So I think the combinations of ibrutinib and other agents are very interesting, and we will be seeing, hopefully within the next year or 2, the results of these studies. So there are obviously, given that ibrutinib has been highly effective on patients with Waldenstrom's, but it does have some toxicities that we need to acknowledge, including bleeding and arrhythmias. New BTK inhibitors have been developed to kind of see if they are as effective and as safe as ibrutinib in patients with Waldenstrom's. So one of them is actually Calabretonis. This paper was actually published earlier this year, so is available for your review, and will be added very shortly to the National Comprehensive Cancer Network treatment options for Waldenstrom's. So in this study, about 106 patients with Waldenstrom's were included. 14 patients were previously untreated. 92 patients were previously treated. And we can see that the overall responses to therapy are over 93%, over 90%, with major responses approximating 80% in both groups. Now, interestingly enough, there seems to be some efficacy in patients without MYD88 mutations. This is a very small group of about 14 patients. It's not really that large. And we also need to understand that it is not very well understood how the definition of MYD88 wild type was made. They use a specific genomic testing platform that is not the standard that we tend to use at Dana-Farber. So we need to understand that the testing might be a little different than what we do here. But in any case, the response rates on these patients was approximately 79%, with a major response rate of 64%, giving us maybe an idea that patients with MYD88 wild type disease might respond to acalabrutinib. This is the progression-free survival, and if we cut off the data about 24 months, we see that anywhere between 80% progression-free survival rate for relapsed patients, 90% progression-free survival rate for treatment-naive patients, very effective treatments. The grade 3-4 side effects include decrease in the white blood cell counts, decrease in platelets, and increased levels of liver function tests, infections, and anemia. One of the side effects is also a headache that could be, present very early in the morning and typically gets better with some coffee. There's also some data that it can induce atrial fibrillation. The rate on this study is about 5% with acalabrutinib. The other BTK inhibitor that is also, progressing in its clinical development is zanubrutinib. This is the ASPEN study that was divided in two different studies. In one of them, the main study, patients were divided between getting zanubrutinib as a single agent versus ibrutinib as a single agent. And there was a third group, a second study called Arm C, in which if patient did not have NYD88 mutations based on genomic profile made by NeoGenomics, they will get into zanubrutinib and they will not be randomized to ibrutinib in that specific scenario. All these treatments, acalabrutinib and zanubrutinib, as well as ibrutinib, are to toxicity or disease progression, which means the treatments are of indefinite duration. Some data on the ASPEN study has been presented at the most recent ASCO and European Hematology Association meeting. And this is essentially the data that has been published. And we have here that with ibrutinib, we have a major response rate of 78% versus 77% with zanubrutinib. However, if we look at VGPRs, which is a very good partial responses, at least 90% decrease on IgMs, we see that zanubrutinib is about 28% versus 19%. The company was aiming at seeing a 20% difference on the deep responses and the VGPRs. They were about 9%. So obviously you can look at that from two different aspects. On one hand, you can say, well, it was not 20% and therefore might not be as good as we thought. Or you can say, well, they induce at least a 9% difference. So that might account for something for some patients. At the 12-month mark, progression-free survival were very similar between the two groups, anywhere between 87 and 90%. And the overall survival is also very similar between 94 and 97%. What the difference was in between these two interventions was actually on the rate of atrial fibrillation. Patients with zanubrutinib, 102 patients were exposed. Only 2% of patients developed atrial fibrillation within that time frame, while 15% out of the 99 patients on ibrutinib developed atrial fibrillation. So that difference could be clinically significant. A little bit more hypertension as well with ibrutinib than zanubrutinib, 17 versus 11%. The risk of bleeding, 9 versus 6%. There was more neutropenia, however, in patients with zanubrutinib at 30% versus 13%. The Arm C results were also presented at the ASCO meeting by our friend Dr. Garcia Sanz in Salamanca, Spain. And we can see here that some responses were also seen in patients with MYD88 wild-type disease to zanubrutinib. And the major response was about 50% with an overall response rate of approximately 80% in VGPRs in 27% of patients. So this was an experience of 28 patients. 5 of them were previously untreated. 23 were relapse refractory. Again, the genomic profile was performed by NeoGenomics, which is a clinically validated platform for evaluation of MYD88 mutations. And the PFS rate, the progression-free survival rate at 12 months was around 72%. The adverse events were not really that different than the prior study. So similar rates of some bleeding and some rashes, some cytopenias, as well as some atrial fibrillation. Now, we do have new BTK inhibitors, believe it or not. And we'll talk about what this is. You might not be familiar with some of this, but I'll present the data and see how excited you get about all this. So we need to understand that patients who are on current BTK inhibitors, either ibrutinib, acalabrutinib, or zanubrutinib, might develop resistance to these inhibitors. These inhibitors bind in a specific way to the BTK molecule. And over time, the patients who become resistant to ibrutinib or acalabrutinib or zanubrutinib do so because they develop a mutation in BTK. specifically a mutation in C481S. And that does not allow these, we call them covalent BTK inhibitors, to bind to the molecule so effectively. So it reduces the binding affinity. There are also another group of mutations in another gene called PLC gamma 2 that basically activates the B cell receptor, even though the BTK and renders BTK inactive. So these two mutations have been present in a large majority of patients who are progressing actively on ibrutinib. The graph on the right is essentially data from CLL, which is chronic lymphocytic leukemia, a condition that we also use a lot of BTK inhibitors on. And we can see here that toxicity in the green, Richter's transformation, which is the aggressive transformation, in the blue. But then at the beginning, there's not a lot of CLL progression, but at some point, 3-4 years later, on CLL patients, the red line, CLL progression becomes a little bit more of an issue later on. So understanding how these mechanisms of resistance work in patients with Waldenstrom's, this happens also in patients with Waldenstrom's, and this has been described by our group at the Dana-Farber Cancer Institute. It can help us understand how we can try to overcome this resistance. And based on this, there have been a series of non-covalent BTK inhibitors being developed in patients with Waldenstrom's and also with other B-cell malignancies in which BTK inhibitors are effective. The idea behind these agents is that they do also interact with BTK, but they do not need to interact with 481, then allowing the binding of the molecule to BTK and the inhibition despite the fact that these patients have developed these mutations. So one of these agents is an agent called Ibrutinib, and data was presented by John Allen of Cornell at the hematology meeting last year, at the National Hematology meeting last year. And this is an experience of 27 patients. As you can see there, a majority are CLL patients. There were only 3 Waldenstrom patients, 2 mantle cell lymphoma patients, and 1 marginal zone. These are previously treated patients with a median prior lines of therapy of 4, with a range between 2 and 9. This is a dose escalation study. We started about 25 milligrams, and now with a goal of getting up to about 500 milligrams by mouth twice daily. And currently, this study is enrolling about 300 milligrams by mouth twice a day. So some of increased liver function tests and some decrease in the white blood cell counts are the side effects that we have seen. But at this early stage, we are seeing some efficacy on these treatments. Now, not all of these patients have been previously exposed to ibrutinib, but some of them have. And obviously, more time will be needed to understand the efficacy of these new BTK inhibitors in patients who are progressing on ibrutinib. The other agent that is being developed is an agent called LOXO-305. Data on this study was presented by Dr. Anthony Matto from UPenn at ASH at the hematology meeting last year as well. This is a 13-patient experience, a little bit smaller. Again, previously treated patients with a median prior line number of treatments of 3, range between 2 and 6. And the dosing, increasing doses as well from 25 once daily to about 100 milligrams once daily. This patient has not included any patients with Waldenstrom's yet. As for that report, we had CLL and mantle cell lymphoma patients. But even in these conditions, 7 out of the 8 patients that were evaluable for response actually had a response. And there were no grade 3 side effects, so it seems to be very well tolerated. Of note, not on Ibrutinib or LOXO had been reports of AFib so far, which is interesting. And so now the LOXO-305 study has a number of centers all over the country, the same with Ibrutinib, in which they're actually including patients with Waldenstrom's that either are intolerant to BTK inhibitors or are progressing on BTK inhibitors. So those are studies to have in mind. We have these 2 studies open at Dana-Farber, but they're also open in other centers. And the third new BTK inhibitor that I want to talk to you about is ARQ-531. That's another BTK inhibitor that is taken orally once a day. This is the experience so far, presented last year as well by Dr. Rogers at Ohio State. And we have CLL patients, Richter patients, diffuse large B-cell, which is an aggressive lymphoma, follicular lymphoma, and mantle cell lymphoma. So no Waldenstrom patients enrolled in this study as of yet, at least the one that has been reported. The adverse events, decreased blood counts, white blood cells and platelets, some skin rash. It looks like at this time, the dose are going to move forward for further investigation is going to be at 65 milligrams by mouth once daily. This study is also enrolling patients with Waldenstrom's. I do not believe we have it open at Dana-Farber at this time, but there are other treatment options as well. So just for you to know, there are other centers in the country and outside of the country evaluating these new agents in patients with Waldenstrom's. Good. So let's move next to the CXCR4 targeting agents. As you know, CXCR4 not only seen in about a third or 40% of patients with Waldenstrom's, but it also seems to impact adversely the responses to Ibrutinib alone. This is the seminal study by Stephen Trion, in which the responses to Ibrutinib were kind of analyzed separately in patients who have only MYD88 mutation, which is the second column here, and then the patients with MYD88 and CXCR4 mutations, which is the second column, the third column here, and the last column is patients who did not have MYD88 mutations or CXCR4 mutations. And as you can see here, the depth of the response in terms of overall response rates were 100% without CXCR4 mutations and 86% with CXCR4 mutations. The major response rate, again, 97% versus 67%, and VGPRs 40% versus 10%. So not only the depth of the response seems to be affected, but also the time to response as well. The time to get to a major response was about 2 months in patients without CXCR4 mutations and about 6 months in patients with CXCR4 mutations. So there is something about CXCR4 mutations that do seem to affect responses to BTK inhibitors. And not only the depth and the time to response are affected, but also the duration of such response seems to be affected. As you can see, the blue curve on the upper side, that is the MYD88 only patients, 75% patients did not progress up to 60 months into therapy, and about 50% of patients with CXCR4 did progress within 4 years. So the duration of that response also seems to be affected by CXCR4 mutations. So can we do anything better? And there are a couple of studies that I would like to discuss with you. One of them is the study combining Ibrutinib plus Xyloprotein. Xyloprotein is an antibody, a monoclonal antibody, very much like rituximab, but instead of targeting CD20 like rituximab does, target CXCR4. CXCR4 is actually a molecule that is located in the membrane of the malignant cells. So an antibody could potentially target that membrane molecule and then block the signaling of CXCR4 in these patients. So this study has enrolled about 12 patients. I think the enrollment is complete at this time. And Ibrutinib is being given at 420 milligrams once daily, all the way to progression or toxicity. And Xyloprotein was given intravenously, being an antibody, initially weekly for 4 weeks, and then every other week for 5 months, a total of 14 infusions over 6 months, and then Ibrutinib continues. My sense is we will have some data to be presented later this year to get a better understanding of how this combination has worked out for our patients with Waldenstrom's with CXCR4 mutations. We carried this study at Dana-Farber with collaboration by the Leukemia and Lymphoma Society. The other agent that we are looking forward on developing is an agent called Mavarixa. So Mavarixa is also a CXCR4 targeting agent, but it's not an intravenous agent, it's actually a pill form treatment. And patients will be taking this medication once a day. Now, this study is a multi-center study. It's open at Dana-Farber and also in other centers in the United States. I think Colorado has it open as well. And patients will be taking Ibrutinib daily at 420 milligrams, indefinitely. And they will start with Mavarixa at 200 milligram dose once a day for a month. And then we'll go up to 400 milligrams once a day for another month. And then patients will go up to 600 milligrams by mouth once daily, all the way to toxicity or progression of disease. The duration of the study is up to 2 years, but we are foreseeing the patients continuing on treatment beyond the duration of those 2 years. At this time, the study is aiming at enrolling 18 participants, including treatment naive as well as relapsed patients, as long as they were not previously exposed to Ibrutinib or any anti-CXCR4 agent. So very exciting study that could potentially give us a better understanding of, the efficacy of blocking CXCR4 in patients with Waldenstrom's. And I think this can help us beyond that, because there is some data that CXCR4, even though it is active, even in patients who might not have mutations in CXCR4, the activity of CXCR4 might be increased as well, not only in Waldenstrom, but also in patients with other conditions. So I think this could potentially give us an idea of how we can target CXCR4, but beyond patients with CXCR4 mutations. And I think I'm going to finalize then with BCL2 inhibitors. BCL2, as you know, is a molecule that has to do with the programmed cell death. What happens in Waldenstrom's and other cancers is the BCL2, there's BCL2 overactivity in a way that these cells do not die when they're supposed to die, and they immortalize themselves, and therefore accumulating in the patient's bodies. So BCL2 inhibitors, specifically Venetoclax, it's a medication that is designed to antagonize BCL2 and then force the cells to undergo apoptosis and therefore die. Venetoclax has been evaluated in a clinical trial by our group in combination with Cornell, City of Hope, and Stanford, using Venetoclax in patients with Waldenstrom's. In this study, we studied patients on 200 milligrams for a week, then 400 milligrams for a week, and then 800 milligrams for 2 years in the first 6 patients. And then in patients 7 to 30, we did 400 milligrams for a week and then 800 milligrams for 2 years. 31 patients were enrolled in this study, and you can see here that all the patients had MYD88 mutations. About half of the patients had CXCR4 mutations, and about half of the patients were previously exposed to BTK inhibitors. The majority were Ibrutinib, but there were a couple of Calabretonis patients in there as well. Patients had IgMs between 600 all the way to 8,000, and hemoglobins between 6 and 13, and platelet counts between 7 and 400. A third of patients had lymphadenopathy, about 20% had splenomegaly. These are we call these the waterfall graphs, and we can see, each column is a patient, and the longer the column, the deeper the response. And we can see here, if we put a mark at the 25% mark, we can see that approximately 90% of patients had some type of response to Venetoclax. And if we, make a line at the 50% mark, we have that about 80% of patients had a major response. And if we go a mark at the 90%, we can see that about 20% of patients had a VGPR. Now, the gray columns are patients without CXCR4 mutations, and the red columns are the patients with CXCR4 mutations. So we can see that in spite of the CXCR4 mutations, we can see deep responses in patients treated with Venetoclax. So this is exciting. This is a similar graph, but the orange are prior BTK inhibitor patients, and the blue columns are patients without prior BTK inhibitor exposure. And we can see here that, yes, prior BTK inhibitor exposure seems to, associate more with more superficial responses to Venetoclax compared to patients without prior BTK inhibitor, which are the blue lines that are more populated on the right side of the graph. So we presented this data at the International Myeloma Workshop last year, and at the 18-month mark, we had a PFS progression-free survival rate of about 82%. The side effects were relatively benign, neutropenia being the main issue, and we had to use in very few patients growth factors. Anemia and some diarrhea were seen as well on these patients. We are now gathering the data to present and publish this experience, and hopefully this will become a treatment option for patients with Waldenstrom's later this year. So based on the efficacy of this, we have designed a clinical trial combining Ibrutinib and Venetoclax on patients with treatment-naive Waldenstrom's macroglobulinemia. In this study, we're going to do 420 milligrams of Ibrutinib and up to 400 milligrams per day of Venetoclax for 24 months. This is going to be a combination study that is going to be driven specifically at the Dana-Farber Cancer Institute. You can see the clinicaltrial.gov ID on the right side if you want to learn more about this study. And the way we designed this, 50 patients, treatment naive, we are trying to achieve at least a 40% VGPR with this non-chemotherapy combination. Obviously, we're also interested in looking at response rate, safety profile of the combination, and the impact of MYD88 and CXCR4 mutations on the responses to these agents. In our experience, Ibrutinib induces fast and sustained responses in terms of IgM and blood levels. Venetoclax provides a little bit of that too, but dramatically decreases the disease burden in the bone marrow. So I think a combination of these two agents could be really, really interesting in patients with Waldenstrom's. There is already some data on this combination in patients with chronic lymphocytic leukemia in the frontline setting, and it seems to be a winner. So we are very excited about carrying this study. Patients will start on Ibrutinib for a month, and then on the second month, patient will increase the dose of Venetoclax 100 milligrams per day for a week, then 200 milligrams per day for a week, and then 400 milligrams for the duration of the study. Now, I want to bring your attention to the right side of these columns here. There's no arrow, which means that both treatments will be stopped at the 2-year mark, and the patients will not continue therapy indefinitely. We hope that this study will minimize toxicity, will increase depth of response, not only in the IgM and blood levels, but also in the bone marrow and lymph nodes as well. And hopefully this is going to translate into a longer duration of such response as well. So, here you have it. These are the treatment options on the horizon that I am very excited about, and I hope you get excited as well. And as you know, clinical trial participation in patients with Waldenstrom's is highly recommended, and I think you should consider that if you are in a situation in which you think that you could potentially benefit from these treatments. I would like to thank you for your attention.
Thank you, Dr. Castillo, for guiding us to see the treatments that are becoming available for WM patients and encouraging us to participate in clinical trials. We appreciate your taking the time to talk to us today and your continued dedication to treating WM patients and to conducting research studies to find better treatments for WM patients around the world.
Thank you, Peter. As usual, it's a pleasure for me to be here.
Thank you. Our first question actually has to do with Ibrutinib. How successful is Ibrutinib if your bone marrow is negative for the WM genetic markers? And would other BTK inhibitors be more effective given that negative genetic markers?
Yeah, that's a great question. So I think the best way that I have to address a question like this is, how the markers were obtained. If they were obtained in the blood, and they were negative in the blood, and that might be a false negative value. The bone marrow tends to be a better test. Now, not only the tissue is important, but also how the test is run. At Dana-Farber, we use two different techniques to actually 3 techniques to identify MYD88 as well as CXCR4 mutations. So the rate of negative genetic markers at the Dana-Farber is very, very low. I think the most recent analysis that we did was around a 4 or 5% negativity. Pretty much 95% of patients do have these mutations. While outside of the Dana-Farber, sometimes that percentage goes higher. And I think it's because the tests that we do at Dana-Farber tend to be more sensitive, meaning other tests can work if you have 1 in 100 cells that are abnormal or in the sample, while our testing at Dana-Farber can include 1 in 1,000, sometimes 1 in 10,000 can be identified. So I think of all the patients that come to see me in the clinic being negative for Waldenstrom, negative genomic markers for Waldenstrom's, actually half of those patients end up having the markers, just that they were false negative. So, and that's important to understand, because for Ibrutinib, we use Dana-Farber techniques, while for Calabretonis and Xyloprotein, the new BTK inhibitors, the tests were done not at the same level of sensitivity as the other ones. So Calabretonis and Xyloprotein, having that in mind, both medications seem to have efficacy on patients without MYD88 mutations. But again, are those really, MYD88 wild type and not mutated? That is always, a point of debate when we think about this type of thing. So yeah, we believe the data the way it is, these two agents, Calabretonis and Xyloprotein, do have efficacy in patients without MYD88 mutations, while Ibrutinib seems to have a little less, but the testing is different from those. Now, in the Ibrutinib rituximab study, it seemed to also be effective in patients without MYD88 mutations. So I would say yes, but it really depends on the sensitivity of the test that is being done.
Okay, thank you. A follow-up question, and you mentioned both zanubrutinib and Calabretonis. Are hematologists able to prescribe those outside of a clinical trial?
At this time, I think they could be, and I know that some clinicians are. Calabretonis data was published in January of 2020 by our friend Roger Owen in the UK, and the data from the zanubrutinib, the Aspen study, just got published probably about a couple of weeks ago by Konstantin Tam from Australia. So those studies are out. The data is available. And therefore, I mean, could potentially be, prescribed. Obviously, some insurances might or might not, accept, these prescriptions. These medications will make it into the NCCN, the National Comprehensive Cancer Network guidelines, as well as the FDA, maybe. So if that happens, then the approval will be official, let's put it that way, and I think it will be easier to get reimbursements for these medications.
Great, thank you. And another follow-up, someone had asked if you were to compare between zanubrutinib and Calabretonis, which one's better?
Yeah, I mean, there's no formal comparisons between the two, so it's very difficult for anybody to say anything about that. What we can talk about is the differences between those two and what that means to some people. So Calabretonis is twice a day, but it's 1 pill in the morning, 1 in the afternoon. And zanubrutinib is also twice a day, but it's 2 pills in the morning, 2 in the afternoon. So that's 4 pills for zanu, 2 pills for Calabretonis, while ibrutinib is 1 pill per day. In terms of side effect profile, in terms of efficacy, Calabretonis, there was no comparison with ibrutinib. Seems to be very similar. Zanubrutinib, there was an actual study comparing both, but the difference that was seen was not large enough to be statistically significant. But while some other people might say, well, 9% difference maybe is a little bit significant to me in terms of the response, of the depth of response that is seen in this medication. In terms of side effects, it's hard to say anything about Calabretonis. We do see AFib and bleeding with Calabretonis as well, a bit more headache. There's some data in chronic lymphocytic leukemia, in CLL, in which if patients are having side effects to ibrutinib, they switch to Calabretonis, and about 2/3 of the patients who were having too many side effects on ibrutinib are able to tolerate Calabretonis a little bit better. There's no data on Waldenstrom's on that, but there's some data that we can use from other disease. And in terms of the zanubrutinib study, the rate of AFib, the atrial fibrillation, which is a common arrhythmia, was actually lower with zanubrutinib than ibrutinib. Maybe a little bit less rash and diarrhea as well, more neutropenia, which is a decreased number of white blood cell counts with zanubrutinib than with ibrutinib. So I think at the end of the day, saying which one is better is difficult. I think one needs to look at the side effect profile and the efficacy and see if insurances will cover the expense.
Thank you. Next question is, can or should ibrutinib be used in combination with other types of treatment?
Yeah, so at least in Waldenstrom's as of now, the only combination that has been reported prospectively is ibrutinib and rituximab. There are a number of clinical trials, as you saw during my presentation, in which ibrutinib is being combined with proteasome inhibitors, with chemotherapy, even with Venetoclax, and other medications against CXCR4, like Xyloprotein and Mavarixa 4. It is being combined with daratumumab. So, we are going to see the results of these combination studies, hopefully, within the next year or two, and we will see what the role of combinations are specifically at that point. At this time, as of today, the only combination, formally published is ibrutinib and rituximab.
Okay, thank you. And the next question is there a second generation ibrutinib on the way?
Yeah, so I think there are novel BTK inhibitors, right? I call them the new BTK inhibitors, which is Calabretonis and Zanubrutinib. Tirabrutinib is another one that is coming out from Japan as well. But all of them are very similar in terms of how they bind to BTK. They bind using specifically a hook in the protein number 481. The problem is that there's a mutation that can develop in there. The BTK mutation develops in there. It's a mutation called C, as in Charles, 481S, SAM. So basically, if a patient will be to develop a mutation in that specific spot, for example, Ibrutinib, Zanubrutinib, Calabretonis, and Tirabrutinib likely will be ineffective. Now, there are new BTK inhibitors that are actually binding to BTK, but they do not need to use 481 to bind. So even if patients were to have the mutations, there is a chance that these new BTK inhibitors, will still be effective because, it doesn't matter if the patients have the mutation or not. So these are two agents that are in clinical trials. One of them is called LOXO305, and the other one is ARQ531. There was another one called Decabrutinib, which the clinical program has been shut down by the company because they felt it was not as effective as they thought it was going to be. So we have one player down, but the other two are going strong.
Thank you. And the next question actually kind of relates to one of the answers you gave regarding Zanubrutinib and Calabretonis, that they can be prescribed, but you'd have to convince the insurance company in some cases. So is there any best way to appeal, if possible, if it does get rejected initially by the insurance company?
Yeah, so only God knows what's going through their minds, right? We need to adjust the best we can. So there are different ways of approaching this. So if a patient is already on Ibrutinib and I want to switch, there has to be a reason. Either the patient is not tolerating, most likely is not tolerating Ibrutinib. If there's too much toxicity to Ibrutinib, one could make a case and say, well, the patient is on Ibrutinib, we try to decrease the dose, and still, the side effects continue, and therefore the patient might benefit from being on Zanubrutinib or Calabretonis. I think that will be one way to get these medications approved, which I have used in the past, and it has worked, at least, in my experience. The problem is if somebody says, oh, I want to switch just because the side effects are better, but I'm not having any side effect at this time, and my response is great, then that's very difficult to convince the company, the insurance company, to cover for another medication when this one is already working and you're having any problems with it. So it's a little bit more complicated than just deciding to switch. So my sense, if somebody is having a good response and tolerating the Ibrutinib very well, there's no reason to switch. But if there is a toxicity, then that's a different story. I think that would be the more valid, explanation, to get this new medication.
Thank you. The next question has to do more along the lines of cost as being an issue that patients have to face now with the newer novel agents. Do you foresee costs being considered before thinking of a treatment as a breakthrough?
I think that's the way it should be. I train in Mexico and Peru. I practice in Mexico and Peru, so I'm very conscious of these type of expenses associated with society. In the United States, that seems to be less of a concern, at least until now. But at some point, this is going to catch up. I think the models that are being followed in other European countries in terms of cost effectiveness is something that we should consider, specifically because of the expense associated with these medications. But again, that's a policy issue. That's a policy issue that needs to be resolved at that level, and it should come from the high up, from the high up down type of ordinance.
Okay, thank you. The next question is regards Zanubrutinib or Ibrutinib, I guess, or BTK inhibitors. Do they have any type of impact on the kidneys?
They're not supposed to. Basically, at least on the initial studies for Ibrutinib, for Xyloprotein as well. Really, even with filtration rates, kidney filtration rates as low as 30, these medications can be prescribed without those modifications. What we have seen in some patients on Ibrutinib, just because of the length of the follow-up, is some patients do, develop progression of disease while on Ibrutinib, and that can manifest in different ways. And that can manifest from IgM increasing to neuropathy progressing to, kidney progression of pleural effusions, right? The way the disease progresses after treatment. But, we can make a case that maybe we have seen some cases in which the kidney function has increased a touch with Xyloprotein and Ibrutinib, but from that to make it, a side effect that, we need to stop treatments for and things like that, I don't think that's at that point. Obviously, every side effect needs to be graded, right? And we do grade every side effect. And there are mild side effects and moderate side effects and severe and highly severe, and obviously depending on the severity of the increase on the kidney function and how convinced we are that there's a relation between the drugs and the kidney function, then we need to, think about that. I would say there's a possible impact of these medications on kidney function. And obviously that relation is to be evaluated by the clinician.
Okay, thank you. This is a somewhat related follow-up question with regards to side effects of treatments. Someone had asked if you're treated because one of your symptoms is anemia or fatigue, and yet some of the treatments that you're given can cause anemia and fatigue. How do you manage that?
Yeah, so the idea behind this is if a patient is coming into CIMIC with a hemoglobin of 8, right, and anemia obviously, and fatigue, then if the treatment is going to make that hemoglobin go up to 13, the patients are going to feel better, So even if their hemoglobin could be 14, but it's 13 because of the drug, the patient should still feel better. So that's essentially the way we look at it. So in some patients, we have seen some fatigue, some anemia at the beginning of the treatments, and then the anemia resolves and the patients feel better afterwards. So when they say anemia and fatigue because of the drug, typically it's not a permanent anemia. It's typically just a transient anemia and that resolves afterwards.
Great, thank you. The next couple questions have to do with neuropathy. What are the newest interventions and drugs for WM patients who have anti-MAG neuropathy?
Unfortunately, there's nothing new there, at least that we can use now. When patient presents with anti-MAG neuropathy, we need to think about, do they have MGUS or Waldenstrom's? Because MGUS, is not a malignant process per se, so we have more limited options. Now that is changing. As I am part of the National Comprehensive Cancer Network, we have decided that even patients with IgM MGUS without Waldenstrom's who have neuropathy, and the neuropathy we think is related to the disease, then those patients should benefit from treatments like Waldenstrom's. So I think that is going to open up some possibilities for patients without Waldenstrom's, but with bad neuropathy to get treated with medications that could be more effective than just IVIG or just rituximab or just steroids, for example, which is what we use in MGUS. So based on that, we could potentially use in the future protein inhibitors, chemotherapy, rituximab, Ibrutinib, and Calabretonis and Xyloprotein for these conditions. So, for example, we'll now be opening a clinical trial sometime next year using Calabretonis and rituximab for patients specifically with anti-MAG neuropathy at Dana-Farber. So that's one thing that we're trying to do specific for that group of patients. And there's a company in Switzerland that we have been in contact with who have developed a medication that actually dislodges the MAG from the nerve sheath. And they have completed some animal, studies, and they are running some safety studies in Europe. And I think it might be ready at some point, maybe next year, to start efficacy studies in patients with IgM, MGUS, and Waldenstrom's. So we actually already partnered with them, and we'll be potentially, developing clinically this compound. The only caveat that I see about this, it sounds great, right, as the mechanism of action of dislodging the MAG from the nerve sheath. The problem is I don't think it will do much for the disease itself. I don't think it would actually do much for the Waldenstrom's itself. It will improve the neuropathy, but it wouldn't do anything to the Waldenstrom's malignant cells. It might not. So we need to think about how we develop this medication, maybe in combination with some other agents, but that's something for the near future.
Thank you. We have about 5 minutes left, so I have time for a couple more questions. The next question regarding neuropathy actually is, are there any new developments in the area of electronic brain stimulation that have worked for patients with Waldenstrom's induced neuropathy?
Yeah, me myself, I don't have a lot of experience with this electric brain stimulation. I think the Mayo Clinic might have a little bit more experience about this specific thing, the intervention. I typically do not use it. I know some of my patients have, and those are the patients that typically are more refractory to treatments or more, therapy has been not really worked too well. But I personally, I cannot tell you how well it works.
Okay, thank you. Next question is actually a follow-up question that actually has to do with the Ibrutinib again. And you probably get this question a lot. What's the attitude about lowering dosage of Ibrutinib to reduce side effects while you're still monitoring your IgM levels?
Yeah, we do that up to some degree relatively often. So we were just, during the prior question session, I was actually mentioning that we are, kind of gathering our experience with Ibrutinib over 8 years. And I would say probably about 20% of our patients end up decreasing the dose of Ibrutinib from 420 to 280, and about a handful of patients all down to 140. And those decreases are mainly driven by toxicity. So yeah, we do have some data, which is obviously not formally presented yet, but I'm working on, that actually there might be a good number of patients who might sustain the responses, even after the dose is decreased because of toxicity. Now, the only caveat, I think, is that those patients tend to have a good response to begin with, right? So it's not like a superficial response and then we decrease the dose. It's typically a very good partial response. There's a toxicity, and then the dose is decreased. But I think it is possible. And I think it is possible that patients would remain on a good response even if the dose is decreased.
Thank you. And I think the last question here is, I'm going to jump ahead 2 or 3 slides, but what's the next silver bullet that we should be keeping an eye on? I mean, you talked about a look in the future. Should we be keeping an eye on Venetoclax, or are there other treatments showing great promise, in your opinion?
Yeah, I mean, I think as I always been promoting what we call, personalized medicine, and I think the reason for that is because there's not 2 patients with Waldenstrom that are exactly the same. And that means, and I think biologically and clinically are not patients that are exactly the same. So I don't think there's going to be a silver bullet. I think we're going to have to develop silver bullets in combinations that are going to be very specific for specific patients. And in some patients, one drug will do great, and in other patients, a combination of other drugs will do great. So I think Venetoclax is the next addition. We're gathering the data for publication for the phase 2 study that we've been running since 2015. Finally, we want to provide some data on that, and we're going to combine it now with Ibrutinib. So I think another silver bullet, and again, it's a plural issue. It is essentially anti-CXCR4 agents, right? Thinking about how CXCR4 affects sometimes the efficacy of Ibrutinib in medications like Ibrutinib, then maybe targeting CXCR4 could be a good option. Why? Because not only the 30 to 40% of patients with Waldenstrom's have a mutation in CXCR4, and that's why CXCR4 is overactive. Actually, in the large majority of patients with Waldenstrom's and other cancers, CXCR4 is overactive even if you don't have a mutation. So an anti-CXCR4 agent could potentially be beneficial for patients with mutations, patients without mutations, and patients even with other conditions that are not Waldenstrom's. So I think, at this time, Ibrutinib combinations, BCL2 inhibitors, and anti-CXCR4 agents are probably the most exciting, agents to be developed, I would say, in the next few years.
Thank you, Dr. Castillo. And thank you for taking the time to speak to us again today. We really appreciate your responses and your guidance with regards to the future for Waldenstrom's macroglobulinemia treatment methods. At this point, we'll be taking another 15-minute break and then be back at 1:30 for Dr. Treon's presentation. Thank you for taking such great care of us, Dr. Castillo.
Thank you, Peter. It's truly, truly my pleasure. It has been an honor for me to be here and answer these questions.